I'm Dr. Erica Bove, and welcome to the Love and Science podcast. I'm your host, and also the founder of Love and Science, Thriving Through Infertility. I'm so excited you're here today. With over a decade of experience helping thousands of women just like you, I empower professional women to build their families with confidence and compassion. Let's dive in. I wanted to share another story about an amazing client of mine who came to me with a very long journey, and she was ultimately successful. So she actually had secondary infertility, which I think is its own kind of pain. And her first child was conceived after 5 years of trying. She had just made an appointment with her REI when she ended up having a positive pregnancy test. But 5 years, my friends, that's a long time to try to have a child. So she delivered that child. They started trying again after that child was born. And unfortunately, they had a miscarriage. And this was absolutely devastating because they had always envisioned a family of 2 children, right? And they really thought this was going to complete their family. And when the loss happened, it took something from her that really needed to be made whole again. And so she had already done one IVF cycle after this loss before coming to me. The cycle had gone very badly, and unfortunately, there were no euploid embryos. And she was in her late 30s at this point and was given a diagnosis of diminished ovarian reserve and male factor. And so we know that when there's that combination, options are really limited. But she was like, my first IVF cycle was not successful. Like, what is this going to be? So she joined Love and Science. Her next IVF cycle actually was fruitful of a euploid embryo. And I will say a lot of things went into this, right? It was looking at her stress levels. She ended up going from an employed position to per diem because that was more conducive to investing in her emotional health and the physiological importance, the regulation that's involved in reducing the hypervigilance, putting in the work, and getting into a place of calm and trust and belief. So I will say she came in with limiting beliefs, as we all do, and she was able to peel the onion, let go of so many of those beliefs. In her first IVF cycle, even though it was somewhat of a roller coaster, right? As there's so many data points, it was ultimately productive of a euploid embryo. So her next frozen embryo transfer, the first protocol was canceled, right? That was not the right protocol for her, but then did a different protocol and transferred her one euploid embryo, and she delivered a second child not too long ago. And she is over the moon. I think that her story, she wasn't with Love and Science very long, right? She was probably with us a total of 5 months because she was able to finally generate a euploid embryo, have a successful transfer, and then graduate from her REI. And so just looking at what she did, right? She was thoughtful. She was calm. She, tinkered with the science. She asked her REI important questions. And she was also able to get her nervous system to a place that had the optimal chances of a successful outcome. So again, this story is so common. I see this all the time. There's so many pieces in her story, which I believe led to her successful outcome. But I celebrate her, and I love getting the pictures of her little one and her whole family because I know how hard she worked for it. And I really believe that Love and Science was instrumental in her growing her family. Hello, my loves, and welcome back to the Love and Science podcast. Today, we're going to talk about something which is a really important topic, which is how to think about unsuccessful IVF. Now, this could take many different forms, right? I think that even the definition of unsuccessful IVF can be debated even among us REI specialists. And so I'm going to give you my perspective. I can give you, evidence from the SRE guidelines and ASRM and all sorts of other, expert opinions as well. But I think that if it's you and IVF has not worked thus far, it can be very threatening. And we're taught that IVF is the most successful option. And the further and further we get down the pathway of, well, I'm expending all of my options, or I don't have any options left, or if this doesn't work, then, I'm not going to become a parent. I think that can be a very scary situation. And quite honestly, that's usually where I meet my coaching clients, is when treatments haven't worked and there's the concern that treatments aren't going to work. And people's REIs are shaking their heads like everything looks okay on paper. I'm not sure why it's not working. And, my friends, my colleagues, my clients, are at a loss, mostly female physicians who are spending their lives, dedicating their lives to medicine and in whatever branch of medicine that is. And when the science is not working for them, and it quote unquote should be by now, I think it can be a very, very scary situation. So I'm hoping to take some of the fear out of this situation. I'm hoping to share how I think about it, because I do think that we need to look at things very objectively. And a lot of times when we say that things haven't worked yet, you know, maybe all the stones haven't been unturned. Maybe there's a diagnosis that is the reason why IVF hasn't worked. Maybe there's another treatment pathway that's actually going to be more successful and beneficial for you. Maybe there's a mind-body connection that needs to be reconnected and the nervous system needs to come down and we need to pave the way for the optimal fertility physiology. Like, there's so many things that can be contributing, but I hope this to be a very empowering podcast episode, because I really do believe, last time I ran my numbers, over 90% of people who had worked with me ultimately became parents or were on their way, had graduated from their REIs. I really do think there's a way through for most people. And I think that we have to take an empowered stance. We have to find the reasons for authentic hope. We have to, look at the mindset and look at the thoughts that we're having. We have to look at the energetic state that we have in our systems and choose the best way possible. Like, there's so many different layers to this, but I'm going to take my clinician hat right now and walk you through how I think about unsuccessful IVF, because this is one of the most common questions I get right now. It's one of the hottest topics in our field. And I also think that from the patient perspective, it is one of the most, important questions that we can answer. Okay. So when I see somebody, whether it's in my clinical world or in my, my coaching world, where IVF has not thus far worked, I always ask the question, like, what are the chances that IVF would have worked by now, right? I want to know somebody's pregnancy history. I want to know somebody's IVF journey. I want to know, is this IVF in the context of infertility, or is this IVF, in the context of other reasons, like genetic reasons or desire for a large family size in the late 30s? Like, those are all questions that really, really matter. I want to understand, just like the ESRI guideline says, like, what are the chances that IVF, quote unquote, should have worked by now? And, how many transfers has this person had? What were the circumstances? What were the protocols? What was the lining? What was the embryo quality? All those things. Because if you look at one embryo transfer, right? Like, we work so hard to make these embryos. We finally get to the point of an embryo transfer. We do the 2-week wait. It's very painful. When we get a negative test result, it can be very, very disheartening, shocking, devastating, all of those words, because if IVF is the most successful option that we have, if even IVF doesn't work, then what? Now, what I will say is that with one embryo transfer, when that doesn't work, emotionally, it is absolutely devastating. From a clinical perspective, it's almost like flipping a coin. And I don't say that to be callous at all. But one thing that helps me think about this as objectively as objectively as possible, is to look at the statistics, to look at the probabilities. Because if you look at it with enough embryo transfers, especially in a thoughtful environment, most people will get to their goal. But the question is, okay, if it's one transfer, was that embryo tested or untested? If it's two transfers, same question. Is there anything that I'm worried about from an environmental perspective that would make a high quality embryo less likely to take? So recurrent implantation failure, how do we define that? There's an equation in the ESRI guideline. Thinking about it, you can say, okay, well, was there over a 60% chance that this embryo should have taken and it didn't? If it's untested embryos, maybe somebody's had a couple of untested embryo transfers and they're young, and we would think that there's, chances are more likely than not that IVF would have worked by now, but it hasn't. And so we got, definitions are all over the place. But I also think, okay, if this is one embryo transfer, we look at things objectively, but maybe we stay the course. Maybe we don't do additional testing and maybe we proceed on. Obviously, depends on how many embryos people have and how hard they had to work. If they took 5 retrieval cycles to get to an embryo, that's very different than if somebody generated several euploid embryos on one transfer, on one retrieval cycle. But I think, again, thinking about things in the context of people's overall situation is very important. So I like to try to ask the question, the why of things, right? Is this just probabilities? Was this just that, it was a mismatch? Was this just that again, you can't assume this, but it was that maybe this was not the soul that is meant to be yours, and that if we keep trying again, that the right embryo, that is meant to be yours will take. There are so many things that we don't understand. Why is not every embryo transfer successful? If I had the answer to that question, I would be out of a job, because then we wouldn't need any specialists. We would just have 100% efficiency, and then it would be a very quick process. But there are a lot of unanswered questions. And so, when I put my thinking cap on to help a person or a couple, I think about, okay, like has the evaluation been thorough and complete? Things that I want to really understand. Chronic endometritis. I just did a webinar on this. We know that chronic endometritis is pretty common. 8% of people walking around on the street have chronic endometritis. When you look in a patient population of people who have recurrent pregnancy loss and infertility, that number is a lot higher. And then when you look at, maybe even a third of people, right, will have chronic endometritis. When you treat the chronic endometritis, I mean, have a diagnosis, give antibiotics, and then do a test of cure and eradicate it, and then move on forward with a transfer, people's outcomes are improved. And when I say outcomes, I mean pregnancy rates are improved, ongoing pregnancy rates are improved, and miscarriage rates go down, both in the first, second, and third trimesters. And so intrauterine fetal demises are decreased when we treat chronic endometritis from the beginning. So I think this is a really important thing. I love to have this data before I move forward for my patients and my clients, because, why would we proceed if we were concerned that somebody had chronic endometritis? It's something that is it's not easy to screen for because it's painful, but especially if I'm doing a hysteroscopy, I'll always check. I'll always send off the tissue. I will always ask my, patients if they want screening ahead of time, especially if I'm already there for another procedure. Looking at CD138 cells, looking at how many, plasma cells there are per high-powered field. That is a whole other topic in and of itself, but one of the major reasons why high-quality embryos don't take is chronic endometritis, and many women truly have not been screened for it. Maybe they had empiric antibiotics and no actual pathological testing. These things are very important. So that's one important question to ask. Another important question to ask is there any occult endometriosis or adenomyosis, right? I have a whole podcast with Dr. Behbahani about endometriosis. We also touch on adenomyosis. But when the environment is pro-inflammatory, that reduces the chance for success. And so what we're seeing more and more of is patients and clients with unsuccessful embryo transfers over and over and over again. They get either, the Receptiva test, which I know is not perfect, but shows that they have, evidence of endometriosis, or they even have a laparoscopy, which the nice thing about laparoscopy is that there's treatment as well. So we know we can excise the endometriosis with surgery, and then that whole environment is much cleaner and less pro-inflammatory. And the data show that when that happens, either with Lupron plus letrozole suppression or surgery, that outcomes are better. And I think we have to be thinking about endometriosis. And the hard part is not everybody with endometriosis has symptoms. Sometimes it's the person with the smallest spot of endometriosis that has horrible symptoms. Sometimes it's the person who has stage 4 endometriosis that doesn't have any symptoms whatsoever. But one could argue that infertility and recurrent implantation failure are symptoms, in fact. And so I'm thinking about an evaluation for that on the earlier side, or maybe empiric treatment if you don't want to have surgery. That's a whole other topic, but always asking yourselves in the question, if you've had debilitating periods, one of my clients said, my ultrasounds are just always pretty tender when they look at that left side, or, I always tend to bloat, like bloating or dyschezia, thinking about that as well. There's all these things that we just quote unquote deal with as women that are actually problematic. Dyspareunia, right? Especially deep dyspareunia. Sometimes we have a lot of those breadcrumbs to the diagnosis that maybe we explain away with other things. Endometriosis is really common in people with infertility, especially people with recurrent implantation failure. And so really thinking about, what's going on under the surface, even, recurrent pregnancy loss. I know that's also controversial, but if it's a pro-inflammatory environment, a lot of times even euploid embryos don't do as well. Even if they take, I do see a higher loss rate in people with endometriosis. And so oftentimes getting that cleaned out, starting afresh, that can be all people need to finally get them to a successful outcome. It's very powerful. So evaluation for endometriosis, which again is different than endometritis being inflammation of the uterine lining, endometriosis being glands and stroma of the uterine lining outside of the uterine cavity itself, usually in the pelvis, but sometimes other places, and really making sure that those two have been thoroughly evaluated and treated if needed. Hello, my loves. I am so excited to share this news with you. If you are a female physician navigating the fertility journey and you want a structured, evidence-based plan,
I have created a free resource for you. It's called the Physician Fertility Roadmap. I have created a guide to help you optimize your chances of pregnancy and a successful outcome over the next 6 to 12 months. Check out the link in the show notes. Love you. Bye.
Hydrosalpinx is another one. And so if somebody is coming to me with multiple unsuccessful embryo transfers, it's really important to make sure that we've screened for hydrosalpinx. Now, how do you do that? Really, a hysterosalpingogram is the gold standard test for looking at hydrosalpinx. So that's done in an X-ray facility. We put a speculum in, clean off the cervix, small catheter, iodine-based contrast. So if you have an iodine allergy, that can be a problem, but most people don't. And so we do the HSG. We look at the outline of the uterus and the fallopian tubes. If there is a dilated fallopian tube, chances are that it's cutting your success rates in half. And so with removal of that dilated fallopian tube, we can often see people's success rates go back to where they would have been without the hydrosalpinx. And so, I have seen people truly go through all of their embryos. I even had one patient once she finally decided to conceive with donor egg IVF after she had used all of her embryos and did not want a surgery for hydrosalpinx. And, at the end of the day, she built her family and it was what she wanted. But again, I do wonder, I would say nudge and say, hey, you've had another unsuccessful cycle. You have this open hydrosalpinx. It comes and goes. I know, Dr. Bove, right? So again, patient autonomy is important. But again, my goal is always to help accelerate the process to people building their families. I want the timeline to be as efficient as possible, and I want the amount of suffering to be as little as possible as well. So I just wanted to share that because I think that, sometimes we don't think about that. It's not always evident on even a sonohystogram sometimes doesn't necessarily show a hydrosalpinx. Two-dimensional ultrasound often will not show it. If you are looking, mid-cycle is kind of the time when it's has the highest likelihood of showing up because that's a very exciting time. The estrogen's high. But again, you can always miss it too. And so thinking about that, it's an important thing to screen for. Also, like inflammation in general. And I know that's a really hard thing. Like people who have autoimmune disease, if that is flaring, that can be a reason why, people have a harder time getting pregnant, staying pregnant. PMOS, which used to be called PCOS, is a pro-inflammatory state. Interestingly, when we look at like GLP use, people are getting pregnant outside of IVF even before the weight comes off with the GLPs, which I know is controversial. I know we don't have full data about birth defects and such, but that just shows how powerful it is that when we reduce the inflammation, that people are more fertile, the environment is more hospitable to people getting pregnant and staying pregnant before the weight even comes off. I think that is fascinating data that we really need to pay attention to. So if somebody says, Dr. Bove, I've gained 40 pounds with these fertility treatments and, I really just don't feel like myself, I can tell you I've helped patients and clients alike by saying, you know what, like let's take a 3-month pause. Let's get you on a GLP. Let's help you get off some of the weight that you've put on through the process. And then, invariably, a lot of times their next embryo transfer is, successful. Also, this can also go along with endometriosis as well. So I think we have to think about outside the box with these things. We have to think, not just in terms of like this quality embryo, this uterine lining thickness, this pattern, like we think in terms of these check boxes, but we have to take a more holistic approach to ask, okay, what's going on at the level of the body? Are there any chronic conditions which are increasing the inflammation in the system? Is there any occult endometriosis, PMOS? I mean, there's a lot of female physicians who manage their weight by exercising, I don't want to say excessively, but like kind of on the high level. I'm probably one of them. I have PMOS, as do many people in my family, and I've always just exercised a lot. So what is that? Well, fertility specialist told me once that I would be infertile because of PMOS and HA. So again, there's that part of my story as well. I've kind of lived it myself. But again, I think that, people have, especially female physicians, if you went to med school and I do, have this like notion of PMOS, PCOS is like the textbook image of somebody who carries a lot of extra weight and is hairy and has acanthosic nigricans. And that's not always the situation. I can't tell you how many people I have seen who are on the PCOS/PMOS spectrum, where maybe they have like a little bit of acne, but they're lean and they have a high AMH, a high AFC. We know if they gain 50 pounds that a lot of these things would unmask, but the reality is that people are managing a lot of the other things with diet and exercise. And so again, is that the optimal environment for an embryo to implant? Maybe not. And maybe some of those people would even benefit from a microdose of a GLP because we know that the testosterone pathways are involved and we know that the insulin resistance pathways are involved. And you have to wonder if several embryos haven't implanted, like what's going on under the surface. So again, I know this is a little outside of like where we have gotten in terms of our data, in terms of our field, but I have seen it anecdotally. I've seen it with my patients and my clients, and it's undeniable. I talk with my endometriosis expert friends like Dr. Behbahani. She believes in it as well because she sees it in her practice. And sometimes our knowledge advances beyond the data that we have for it. And that's when we need to do the well-designed studies to show. Again, sometimes we have a null hypothesis and we have to accept that. But I think that if the shoe fits, if it's biologically plausible, as my mentor, Dr. Randolph, would say, like we have to explore what might be going on under the surface. Okay. Other questions are about uterine factor. So this is also a huge, huge, huge topic. And oh gosh, if it's a whole can of worms, right? We recently saw that there are, studies that are controversial looking at history of IUD use and infertility. I am of the camp that I do think that there's probably an effect there, not for everybody, but for some people. The, uterine lining does have the different layers, and there's the basalis layer, which is the layer with the stem cells. And when that layer gets denuded, when it gets affected by a vigorous DNC, which, by the way, is often to save somebody's life. So if that's been your situation, your life was saved, and you have, Asherman's as a consequence, it's one of those things where, again, you can't really pick those things apart, and you got to treat the Asherman's. But I do wonder if some of the IUDs, especially the progestin-containing IUDs, depending on how, they are situated once they're in and where those arms are and where they're poking. I have met a lot of people along the way, a lot of my patients as well, who I do think have had, chronic uterine factor issues related to IUD use. This also seems to be compounded in people who have hypothalamic amenorrhea. So again, I'm speaking from my clinical experience here. My expert status is somebody who's seen hundreds and thousands of women with these conditions. But when the uterine lining is chronically thin, related to hypoestrogenemia, we know that when people are lean and they exercise a lot, that their estrogen levels are typically pretty low. It's harder for the uterine lining to regenerate. If you compound that with something like an IUD, which is intentionally made to thin the lining, which might create some chronic inflammation, which might create some scar tissue inside the uterus, you add all those factors together, you create an environment where there is an insult. The body cannot repair itself. It tries to repair itself, which it does through scar tissue, and then you have issues over time. Somebody asked me the other day if I'm going to get an IUD at some point at this point in my life. And my honest answer was like, absolutely not. I manage all the complications from the IUDs. And hey, I think if you're 20 and you have a terrible disease and you're trying really hard not to get pregnant, that may be your best option for all things considered. I also, believe that if you are in your, say, late 20s, early 30s, maybe early 40s, and you're thinking about trying to conceive, taking out the IUD, well in advance of when you're trying to conceive to identify any issues. I think that's important as well. That's been one of the popular topics on social media lately. But again, thinking about uterine factor issues, maybe it's been a DNC, maybe it's even tuberculosis, there's endometrial TB. We don't talk about it a lot, but especially people who are not from the U.S. originally but have come to this country, it is a significant factor, and that's really, really hard to treat. It's also hard to diagnose. So you got to, go to somebody who understands what that means. But again, there are ways through. We have to understand, though, is it that the high-quality embryos are reaching an environment that is not hospitable for them? Or is it that the uterine environment is hospitable, it can be optimized any further, and there's something else going on, such as inflammation? Stress increases inflammation. I'm not saying that this is just related to stress, but again, you've heard me say time and time again, oftentimes infertility is not one giant thing. It's a few little things that line up over time to create subfertility. And if that's happening to you, sometimes all we need to do is align the vectors that we can, decrease the stress, improve the microbiome, make sure that the cycle type is optimal for the kind of FET that's best for you, and, really align all the vectors such that the next transfer has the highest chance of success. And I will tell you, people who work with me at Love and Science, not always, but in the vast majority of cases, like we optimize the science, we optimize the, emotional environment, which of course has a spillover effect on the physiology. And most people who work with me are actually pregnant and stay pregnant with their next embryo transfer, which is amazing on multiple levels. Number one, it's amazing because they, get to their goal faster. there's something about the mind-body connection and trusting the process, finding those reasons for authentic hope, making sure the science is sound, working through the emotional issues. When all those things are aligned, I see the highest chance of success. So that's such a beautiful thing. And then also the cost savings. I always say I know that coaching does come with a cost, but based on my data, I save my clients thousands and thousands and thousands of dollars because of the IVF, the extra IVF they don't have to do along more unsuccessful and more time-consuming pathways. And so again, that's a little bit of an aside, but I want to say that when the science is sound, when the emotional environment is sound, we see really high chances of success. And so at the beginning, like I said, when people are told, oh, you're in the 5% of people, where this should have worked by now, but it hasn't worked, and then people feel like a zebra. Number one, if you look at the studies that looked at that, those studies have significant flaws. They are not generalizable to the general population. Over 99% of people were excluded from those studies because they didn't meet the criteria. So probably you would be excluded as well. They excluded people with severe male factor. They excluded egg donors. They excluded people with adenomyosis. And so again, really like asking ourselves the question, like, can we even generalize this data to us? Like, I don't think so. And then also really looking at the big picture and making sure that we have a thoughtful approach, I think is the most important thing. Okay, so I think now we've talked about like, have I unturned all the stones? Has my treatment team like looked at everything that might be contributing, that might be an environmental issue as to why? Sometimes it actually, a lot of embryos are for one batch. And like, I've seen it before where sometimes we move to like a different group of embryos, like there can be lab effects as well. Maybe those embryos have been transported and maybe something happened in transport. Maybe, there was something that happened in the, in the lab in the cryopreservation process, which I know these things are unusual, but I mean, there's a lot of, you have to go down your checklist and say, okay, where are things breaking down? And sometimes using embryos from a different cycle actually can be quite powerful as well. So I just wanted to add that there's so many variables and we have to look at them all systematically, but there is often a missing link that maybe hasn't been picked up thus far. That is the key to moving forward in a more successful direction. Okay. So once we ask that question, like, has every stone been unturned and have we had the most thorough evaluation possible for all the reasons why high quality embryos might not take? Then we have to ask the question, is the way forward more IVF? And I say this understanding that we have a whole industry of, infertility where the IVF is what makes the money. I completely understand that. And I'm not anti-IVF. I think that IVF is a beautiful technology. I'm so thankful it exists. I have helped thousands and thousands of families who I truly do not think would have conceived without IVF. So again, I'm very pro IVF. But IVF is not necessarily right for every single person. I think that for many reasons, sometimes we move to IVF very quickly because of scarcity, because of time pressures, because of various reasons, because we're told that you need 3 euploid embryos for live birth, for instance. And we have to look at the big picture to say, okay, like maybe less is more. So I can tell you some situations in which sometimes when we take a pause from IVF and then like optimize other things, we can see really high chances of success. So one example is somebody I was working with who had done like a year and a half of unsuccessful IVF, and she really was at a loss. They thought maybe she might have some uterine factor, maybe because she had had scar tissue once. She did have surgery for endometriosis. They took out a little bit of endometriosis, but even her next embryo transfer after that didn't work. And so she was really at a loss. And she really did need to get to the point of saying, you know what? I think my husband and I are going to be okay if IVF doesn't work. For me, maybe we'll use a gestational carrier. Maybe we won't have children. Maybe we'll figure something else out, but I have to give it up at this point. Like, I have to. Would you believe that in that cycle, she actually, like her 1 month off of all of this, because she was traveling, she and her husband actually conceived, and now they have a beautiful baby girl, which is, that story makes no sense, right? It makes no sense because she had done all the things. She had done like 5 egg retrievals to generate these embryos. She had had several transfers of euploid embryos. And, she actually, if you ask her, like initially, she didn't even have a diagnosis of infertility. She had gone to IVF, for various reasons. And so when I hear her story, I just think about the power of aligning the mind and the body, of the physiological power of surrender, which I know sounds kind of woo, but if you actually think about it on the cellular level, there's incredible things that happen when we actually disavow ourselves of the complete responsibility. We hope for the best. We unattach the outcome. That is the sweet spot where I see the highest chance of success. This woman was going to do more IVF. It wasn't like she had said, I'm never going to try to build my family again. She just said, I'm at my limit. I have to turn this over. I'm taking a break. I will pick this up when I get back from my trip. And then there was no opportunity to pick it back up because she...
If you're listening right now and finding yourself nodding along, this is usually the moment people realize that they want support that's specific to them. In addition to this podcast, I offer one-on-one fertility consults where we look at your full picture with both strategy and compassion. You can learn more in the show notes. Now, let's get back to the conversation.
Never got her period and she ended up being pregnant. So that's one example where I think that sometimes pausing and focusing on the emotional aspect of things can have a really positive effect. Another example I have is a patient I saw one time, and I share this with permission, who came to me because she didn't have a diagnosis. Her doctor really hadn't found a diagnosis for her, but they were like, you know what, you probably just need IVF. And so she went and did IVF. She got pregnant with twins initially. She had a terrible periviable loss of twins, which is just horrific and sad, preterm delivery. And she lost both twins. And so she came to me saying, I don't have any embryos left. I was told that IVF was the only way that I would conceive. And I really, really, really don't want to go through what I went through before. And by the way, she also had like hyperstimulation during her IVF cycle. So I sort of zoomed out and looked at the big picture and thought to myself, okay, her AMH is super high. She got hyperstimulation syndrome. She got pregnant with twins. I wonder if she has PCOS, right? PMOS, right? We now call it PMOS. We all have to readjust our brains. So I said to her, I'm like, you may need IVF in the future, but you had a really negative experience with IVF. You're still relatively young. Your egg reserve is good. I don't think you're ovulating. I think you may have this in your story. Maybe not full blown, but maybe you're on the spectrum. Why don't we take a pause and do a few cycles of letrozole, which she had never done before, see if you and your husband can conceive outside of IVF. And if that doesn't work, then we'll pick up IVF again in our center and, generate embryos and just be very careful to put in one embryo at a time. And she was like, are you sure? Like, they told me IVF was the most successful thing. And I said, and this is the importance of having a trusting relationship with your people, like whether it's my patients or my clients. I said, I have this deep intuition that this is the next indicated step for you. And I promise you, like, we're not going to do it forever. But if we've stayed the course and it's not fruitful, we will move on. So would you imagine that she did one cycle of letrozole, she got pregnant with a singleton pregnancy, and then she delivered, a healthy baby. And she was like, what did you do? You have magical powers. Like I finally, got to a good outcome, and it was with so much less effort than I thought. And it really was because it was like taking a pause, taking a step back, asking like, what is the actual diagnosis here? Have we thought of all the things? And sometimes keeping things inside the body is better. I mean, you don't generally get hyperstimulation syndrome from a letrozole cycle. Sure, there's a 3% risk of twins if you do get pregnant, but it's a lot less to go through than the whole rigmarole of like daily injections and an egg retrieval and, all of that she had to go through the first time. And so that's a situation where, maybe people go to IVF very quickly in the beginning. But if that hasn't worked or if it's not working, pausing and saying, okay, what's the diagnosis here? Are the fallopian tubes open? Is there a reliable sperm source that we can count on? And hey, I'm not even talking about heterosexual couples. If it's a single person and they want to do donor sperm insemination, fantastic. If it's a same-sex couple and they want to use some donor sperm, I know it's expensive and not doing it forever, but to say up to 3 cycles of something that's outside of IVF, that's very reasonable to think about, given each person's situation. Obviously, the context matters. But again, I can't tell you how many people I've helped with conceiving outside of IVF when IVF hasn't worked because we zoom out, we think outside the box, and we say, maybe IVF is not the best. It's not the most successful thing for every single person. Okay. Another reason why I might say, maybe more IVF is not, the best thing that we can do. There is a certain patient population, and I think this may relate, depending on your situation, of, late 30-somethings, early 40-somethings who do IVF. They get 1 or 2 follicles, maybe they get 2 eggs. They take them outside the body, they fizzle out, maybe 1 or none fertilize, and the embryo development's poor. Now, if that person has open fallopian tubes and a good sperm source, like normal sperm, that is a person for whom IVF may not be superior. And I'm not saying like we don't, try IVF, but I also think that if it looks like there's one, two, three follicles, maybe three we might go for IVF, but if there's one or two follicles and it maybe looks like history might repeat itself, maybe we convert that cycle to an insemination cycle. Again, I've helped so many people who, when you do IVF, you take the eggs out of the body, you fertilize them in the lab, you try to create embryos, you put them back inside the body, especially in the situation. Like if you don't have any fallopian tubes or the sperm are terrible, like this is not a good plan for you. But if there is the ability of trying to conceive inside the body, I get it. There is the aneuploidy risk. I'm not minimizing that. But sometimes less is more. And there seems to be, and maybe sometimes people even say, I'm actually going to take a pause from IVF. I'm going to do a few gonadotropin IUI cycles, and I'm going to, pick it back up again if it doesn't work. Or, maybe it's somebody, I see this a lot. Maybe it's somebody who's done maybe 3 autologous IVF cycles. They're not ready to move to donor egg IVF, but they also want to keep moving in a forward direction. That's a patient population, say they're out of insurance coverage or whatever. I will often do gonadotropin IUI cycles for those people who are like, you know what, I'm not quite ready for donor egg, but I also want to keep going with my own body. IVF isn't really panning out. Maybe we skip the gonadotropin step altogether for whatever reason. I've had so many people have babies. Actually, I even had one lady. This is a true story. She had 2 unsuccessful IVF cycles with her own body and then with her own eggs. And then we decided to do a gonadotropin IUI cycle. And she actually got pregnant with triplets, which is not ideal, but I think it speaks to the power. And I mean, again, all's well that ends well. She ended up doing okay. She ended up making it through the pregnancy. Like like the babies ended up being okay, which I know is not always the case, but it was for her. But the point is, why is it that 2 full IVF cycles did not work for her? And then when we kept things inside the body, things worked better. And admittedly, this was somebody with secondary infertility. So she already did have one living child, things that already worked inside her body to begin with. So again, we have to interpret this in the, every person's situation. But keeping things inside the body, not manipulating the eggs outside the body. Everything is temperature controlled inside your body, right? Like sometimes the body knows what to do. And so there are some times when we might say, you know what, IVF does not seem to be working with your own eggs. Let's try something a little different and see. And then we go from there. And, at that point, if IUI still isn't working with gonadotropins, then we might say, okay, what do we do from here? It's at that point where we might start thinking about other options for real, like third-party reproduction. Sometimes some people build their families with an egg donor, which, I've helped many, many patients and clients with that. It's a beautiful way to grow a family. It usually takes some adjustment. It's not usually people's strong plan A because there's so much complexity in motherhood and DNA, and like that's a whole other conversation. But I do think that sometimes there is a process involved in coming to that decision and looking at it from all the different angles, trying different avenues, increasing the chances of success with a person's own DNA first. I think that can be very powerful. And also gestational carrier. I mean, sometimes the issue truly is the uterine environment, and maybe somebody's had, vigorous DNCs and they have Ashermans, and no matter what we do, the lining just never gets thick enough or pretty enough, and transfer after transfer cycle are not working, and that seems to be the only issue. Like I know somebody in my own life recently who finally got pregnant through a gestational carrier after so many unsuccessful cycles in her own body, and she's like, you know what? Maybe someday it will work out in my body, but I had to get off the unsuccessful train tracks. I had to do something that was moving in a forward direction. And for her, that was a gestational carrier. So again, there's not one size fits all. Every single option needs to be, selected in the context of a person's situation, their goals, their family building, their finances, and all those things. But I think sometimes just like plowing ahead on the same trajectory, being like, if you throw spaghetti at a wall, something's going to stick. I don't necessarily think that's the best approach for people. And I think it's a sort of a scarcity based. I think sometimes it's if people are in the wrong clinical situation for them and they have maybe not the best relationship with their REI. Again, I think most people do have pretty good relationships with their REIs, but every now and again I see a situation where like it truly isn't a good fit. And like it's just not a good match. And like the lines of communication are not really connecting. That's sometimes a situation to take a pause and sort of ask if there's a different way. But I think, again, to summarize, I think that sometimes high quality embryos are not taking because of things that have not been yet diagnosed in the evaluation. And of course, like that's why we talk about like the thorough and complete way. Sometimes it's that actually there is a diagnosis that hasn't yet been diagnosed, like PCOS or endometriosis or something like that, where having that knowledge can actually change the trajectory of things. And again, PMOS, I'm still adjusting my own brain as well. Sometimes we actually like take a step back from IVF because it's not working, and why proceed down a pathway that's not working, and why don't we try something slightly different if the clinical context would warrant that. And sometimes we actually do need to have conversations about third-party reproduction depending on what the core issue seems to be, and then ask questions if that's a way that people, might build their family. Also, there are people in my life who have built their families through adoption and are very, very happy. And, again, that's not always the last child either. I've had people who have adopted and then went back and did IVF. I've had people who adopted and then ended up conceiving outside of IVF. Like, I feel like I've seen it all at this point. But that can be a beautiful family building strategy to include as well. And I've also seen people who decide to remain child-free, which, from my perspective, if somebody has the desire in their heart to become a parent, I see it as my job to say, okay, well, like, we are going to maximize the chances of this happening for you. And I don't want somebody to drop out of treatment because it just gets too hard and the mental load is too much, or the financial burden is too great, or whatever it is. Like, I want people to say, I have chosen thoughtfully to stop treatment if that is my highest good in this life. I don't want it to be a reaction. I want it to be a response. And so if that is what somebody decides to do, ultimately, I will bridge them to that outcome. I will set them up with, my good friend, Lana Manikowski. She's a coach for people who are child-free after unsuccessful fertility treatments. And that's a very, very important space. I can't stress that enough. But I always want people to make the most thoughtful, empowered choices that they can. And I want people to live their lives without regret and to know that they did the best they could with all of the resources that they had available to them. So again, sometimes that is proceeding on with IVF. Sometimes that's pausing and getting a different diagnosis. Sometimes it's taking a step away from IVF. Sometimes it's pivoting, in a different direction entirely. But the point is, thoughtful, empowered choices are where it's at. This is not a one-size-fits-all approach. And I think that when IVF is not working, we do need to pause. We do need to conserve our resources, financial, emotional, and otherwise, and say, am I moving in the best direction? And sometimes it really does require your A team to help you sort that out. So I hope this has been useful. You know how much I love you. Until the next time. Bye.
Thank you for listening to the Love and Science podcast. I'm so glad you joined us today. If you found this conversation valuable, if you could please rate, review, and share this podcast with your trusted people, it would mean so much to me. If you want more tools to help you navigate the fertility journey, please book a discovery call with me today. The link is in the show notes. Please do not let infertility have the final word. I'm here to take the burden from you so that you can achieve your goal of building your family. In gratitude, this is Dr. Erica Bove. I'm rooting for you always.